going to talk to you about anterior spine surgery primarily in the pediatric population and in idiopathic scoliosis as well as neuromuscular conditions. And the theme is supposed to be when and how. The first thing I would tell you is I don't think I'm going to be able to tell you much in the way of answers or definitive ways to manage these patients. But what I'd like to do is to review some of the indications currently for anterior spinal surgery, talk about methods of anterior spinal surgery, some of which are already coming and going, and talk about some advantages and disadvantages of this approach. And then lastly, try to say where are we in 2006 and how can we approach patients with problems that might be amenable to this. The origins come from a long way back, but they don't come from orthopedics. They come from general surgery, primarily in the treatment of infections and tumor resections. But in spinal deformity, it has evolved into really two areas. One as a definitive procedure for deformity correction, and this began with Dwyer and Zielke back in the 1960s and 1970s. And then lastly, as a combination with posterior procedures, which I know Ted is going to address in one of his talks, but we'll touch on briefly here. Why anterior? The common arguments that have been used have been that you get surgery at the site of deformity, you get better overall correction, better control of the spine for apical derotation, especially in the flexible portions of the spine, better end vertebrae control with less change in the compensatory curves. Supposedly fewer levels fused for deformity correction, arguably less neurologic risk because you're not in the canal itself, higher fusion rates and lower infection rates. And as you pour through the literature, these are all commonly cited reasons. The treatment approaches for the thoracic spine have been varied from open thoracotomy with single or dual rod systems, plate systems. More recently, a big wave of enthusiasm for thoracoscopic procedures, which we'll talk about more in just a second. This is typically done in the lateral position for instrumentation cases, can be done in the prone position quite readily if you're going to do a release case in combination with the posterior procedure. And I think the other tool that we have is costotransversectomy, especially for very highly rotated, very large deformities where you can go through the ribs into the chest cavity and stay extrapleural and actually do a very nice release if that's going to be a part of your surgical procedure. The thoracoscopic approaches, as Peter Newton has showed us, have a very high learning curve. It takes about 50 thoracoscopic cases to get up to speed to where you can actually do it efficiently. Even with that, the operative time is at least an hour longer than it's going to be to do a standard posterior case. There is a brace postoperatively in most regimens that are being used. There is risk to the aorta, and I think this has caused people to back off considerably, as when you're doing a right thoracic curve, especially the tip of this, which you can't feel and palpate like you can in open procedure, can be quite close. And there are many, many now CT scans of tips of screws that are actually impacting or indenting the aorta from cases that have been done. There has been a higher pseudoarthrosis rate that's been documented, especially if you use allograft bone. So if you're going to do these cases, you really need to use autogenous bone graft, or you're going to have a pseudo rate that's at least 20%. The arguments have been that there's less blood loss, less pain, less lumbar decompensation. And I think that as time's gone by, what we've seen is that the indications for this type of procedure have become increasingly more narrowed and more selective to where the incidence now is quite low. You can do an open thoracolumbar thoracolumbar spine. We have a variety of approaches that can be done there. You can do an open thoracolumbar approach, which is the standard way coming off of the 10th rib. You have to take down the diaphragm, and one of the large questions, as Greg has already alluded to, is how does that diaphragm function in the immediate postoperative period and further on down the road. Thoracoscopic open approaches can be done combined with the retroperitoneal approach, and you can also do both thoracoscopic and laparoscopic approaches, but these are extremely difficult to do and require balloon dilation of the retroperitoneal area to get down there. In the lumbar spine, we have more traditional retroperitoneal approaches off the 12th rib. We can also approach this laparoscopically for release cases, but not for instrumentation cases. You can do the conventional transabdominal approach, which is an excellent way to get to the L5-S1 space, and that can also be done through an open or laparoscopic approach, depending on the extent of what you have to do. And I think this is probably most useful in situations of high-grade spondylolisthesis, or as we see in many of the kids with cerebral palsy, in severe hyperlordosis cases, which you can see after rhizotomy or after baclofen pump placement. I think it's controversial in children whether or not you need to use anterior column support. If you're treating predominantly kyphosis deformities, it's clearly of advantage and benefit, and you have improved maintenance of sagittal contours. In the more traditional or conventional scoliosis cases, the idiopathic scoliosis cases are actually comparative series showing that there's not a difference in sagittal outcomes long term, at least for the pediatric population, whether you use cages or other forms of anterior support. So it really becomes dealer's choice as to what the surgeon's preference is. There does seem to be increased stress at the end vertebrae levels biomechanically, so if you're doing a pure anterior construct and you're going to fix this, the anterior column support will help you to decrease stress and potential pullout of the superior screw, which can be problematic at times. Why do surgeons choose not to go anterior? Well, it's an unfamiliar approach. You may or may not involve a general surgeon or thoracic surgeon to help you. There is a large question of adverse pulmonary impact, and I think both Luque's group and Newton's group in San Diego have demonstrated to us that there is a big hit to the pulmonary function in these kids with a decline of vital capacity of at least 20% in the immediate postoperative period. It does come back closer to the normal range by the time you're a year out and 2 years out, but never quite reaches the same level that it was preoperatively. And as Luque has shown in 5-year follow-up, anytime you hit the anterior chest wall, you will have a subsequent loss of some vital capacity growth over time. The implants are smaller in the anterior portion, they're less rigid, so oftentimes postoperative stabilization is necessary, and this is a big downside to kids, especially teenage girls who did not want to wear a brace to begin with. There are now improved posterior systems and posterior fixation, so the question of whether or not you need to go anteriorly, I think, especially for thoracic curves, is really quite controversial. And in the thoracolumbar and lumbar spine, the question has been, do you produce kyphosis inherently with your device because of your need to compress on the convexity? And rod systems, as you know, with the Caneda system have been devised to try to preserve that. You don't need necessarily anterior column support if you can preserve it with your instrumentation, but if you are having a compressing system, then you probably need the anterior column support to get your lordosis at the initial get-go. There are many alternative approaches which are now available, and I think this makes, to my mind, the question of whether or not anterior procedures are routinely needed, at least for primary procedures. For congenital kyphosis cases now, we can do very nice jobs through costotransversectomy and osteotomies from the back. You can do transpedicular resection for congenital abnormalities. We can do posterior instrumentation and fusion with subtraction osteotomies, such as in Schurman's kyphosis now. And with pedicle screw fixation, the need for anterior procedures has really greatly diminished. You can also, in the very young child, use periods of prolonged traction or casting, which can soften up the spine and get you a position that's much better than you began with, and that oftentimes can obviate the need for an anterior approach. I think combination indications is still probably the big area where anterior procedures are used. Conditions with a high rate of pseudoarthrosis, such as this child who has neurofibromatosis, or in myelodysplasia where you have very little bone element posteriorly to fuse to. And I think these are situations where combined anterior and posterior fusion is probably very helpful. The issue of crankshafting in the very young child with the posterior tether and the rotational deformity was highlighted for us in the etiology talk, I think is also a useful indication. But the age range at which you need to do that is still quite controversial. It's probably not necessary in kids over the age of 10. And I think lastly, in large rigid deformities in neuromuscular patients, such as this child with a 150-degree curve, the ability to add the anterior release and an anterior procedure to augment your posterior approach, especially when you have very weak bone and very osteoporotic bone to apply your fixation to, can be quite a useful technique. Arguably, I think in congenital kyphosis, congenital scoliosis, you may want to consider the combined approach. There are advocates of both posterior only and anterior only. Each has their advantages and disadvantages in terms of visualization, in terms of spinal cord risk. But to date, there's really no comparative series documenting that one is superior than the other. So at least my philosophical approach in these situations is use the best of both worlds, look at the anatomy of the deformity carefully, and in fact the combined approach, especially if you have a complex deformity of not only kyphosis, as we see in this kid, but also combined frontal plane scoliosis, may be safer done in a combined approach. And that's been our approach to many of these kids, is to use a combined retroperitoneal flank approach coupled with a posterior approach and direct visualization at the same setting at the same time. So in 2006, I think the anterior approach is still useful in severe deformities, in situations where you have a high risk of pseudoarthrosis and non-union problems. It's also useful if you have a concern for crankshafting in the very young patient and you're committed to the idea that you need to do a definitive spinal fusion. In congenital kyphosis and scoliosis cases, I think in combination with posterior approaches, it can also be a very useful technique. But I think the indications are changing dramatically for isolated definitive treatment. And I think that this has largely been driven by concerns for pulmonary function after invasive procedures. The thoracoscopic indications, I think, for spinal surgery and anterior surgery have narrowed considerably. And I would say even in centers doing a large volume of this, it's only a relatively few number of cases now that they're doing. And these are predominantly in the single thoracic curves, very thin kids who are extremely worried about cosmesis and in which they're trying to correct really what is relatively small deformity. I think alternative approaches are now available with pedicle screw instrumentation, and many anterior procedures now are becoming less useful, and as a consequence are starting to fall by the wayside. Thank you very much.
So we're going to shift gears a little bit here from the anterior to the posterior, which probably I was a little bit more familiar with. Dr. John Smith here from Salt Lake City.
I was asked to talk about posterior surgery and how does it compare. As we know that surgical techniques are driven over time somewhat by fad, technology, what's current, and then a few years later we get the outcome studies and there's a new fad behind. And I think the evolution between older techniques, anterior techniques, minimally invasive techniques, and now current trend back towards posterior surgery is a great example of that. Historically, all surgery was posterior surgery for deformity, and it started first with hips fusions and casting, evolved with technology to Harrington rods, and then an increasing amount of metal producing segmental fixation, and now the current pedicle screw technique. So there's been a huge evolution in both the ability to correct severe deformities and the amount of metal that we see patients have at the end. So why is the current trend really towards posterior techniques? They're becoming increasingly simple again. The instrumentation is clearly improved. There's a better ability to preserve sagittal and coronal balance that wasn't available with earlier technology. We're certainly getting an improved 3D correction of deformity. There's preservation of pulmonary function with posterior approaches, which we'll talk about, and really an improved understanding of what patients can have more selective fusions with a posterior approach. Should or can all anterior surgery be avoided in 2006? Well, not necessarily, but the big questions that are coming up is how significantly is pulmonary function impaired with anterior approaches, and are posterior approaches now with current technology just as effective? Previously anterior surgery was felt to be a little more technically difficult. It was indicated for a limited number of curves, such as thoracolumbar curves, with really the goal of preserving motion segments and having shorter fusion. And if you look at the work of Bob Gaines, who's a big advocate of his bone-on-bone anterior fusion, you can get very nice corrections in selective curves with short anterior techniques. And certainly the thoracoscopic techniques to do anterior-only surgery have been evolving. But the problems with anterior surgery are really the big question of what is the effect of violating the chest on pulmonary function. And these are becoming increasingly understood. With the large open surgeries, there's certainly the cosmetic issue of large scars. There's the question of whether you can really maintain the sagittal and coronal balance and correction that you'd like to obtain. Certainly, these techniques are technically more difficult in most instances, and at least in my hands, have a longer operative time. Well, the pulmonary function data is quite prevalent right now as we're understanding things. If you look at Peter Newton's study of patients with idiopathic scoliosis, in a large series they looked at prospectively at the evaluation of pulmonary function, and the conclusion was really that these patients with scoliosis of all variety do clearly have impaired pulmonary function. And Luque's study in 2005 demonstrated that there was a significant change in pulmonary function with any violation of the chest cage, even as far out as 5 years. The next thing that evolved was the question of whether is it really the approach that we're using to do anterior surgery having a bigger impact on pulmonary function. So as thoracoscopic approaches to doing anterior releases and fusion compared to open thoracotomy came out, it was found that combined with a big posterior fusion, there really was not a huge difference in pulmonary function at 2 years post-op. Other studies have said that there's a significant impact early on, but improves at 2 years. And in general, it's felt that the thoracoscopic approach probably has less overall impairment when compared to an open thoracotomy. The other question that comes up with posterior approaches is who's a candidate for selective thoracic fusions? And the real landmark study came from Howard King when he came up with the King classification, which really, in his type 2 curve, was the ideal candidate for selective thoracic fusion. Larry Luque is come up with his classification of scoliosis, which is really, at least in my view, a variation of the King classification with some more specific ways to try to determine who is a candidate for selective thoracic fusion. The other issue in the posterior-only approach is really related to how good a correction can we get by going posterior only and avoid violating the chest. And there's a lot of studies coming out now that really show that posterior pedicle screw constructs, even in very large curves, are able to get satisfactory correction, three-dimensional correction, coronal balance, etc., with going only posteriorly. Well, there's a number of new, although they're actually quite old, many of them, approaches to doing posterior-only surgery. There's certainly the selective thoracic fusions. There's the Smith-Peterson osteotomies, posterior vertebral resection, costotransversectomy, etc. Smith-Peterson osteotomies are certainly something that's not new, but are currently talked about a lot in SRS and other places. And the ability to do wide facet resections and correct the sagittal plane deformity certainly allows you to get outstanding corrections in sagittal balance in the posterior-only surgery while avoiding anterior approaches. These large curves with Schorman's kyphosis, sagittal plane deformities are almost routinely now being corrected without doing anterior approaches and with excellent sagittal outcomes. Posterior vertebral resection is another way to address very severe deformities without necessarily doing an anterior approach. And some of the advantages of this technique, although complicated and technically challenging, is it gives you very direct visualization of the spinal contents, the direct ability to control venous bleeding during correction. So in a severe deformity such as this, it would be very hard to access this anteriorly, but can all be resected from a posterior approach with good visualization of the spinal cord. So we're finding that many of these very complex congenital deformities are really best approached posteriorly. Costotransversectomy is another posterior approach that allows you excellent access to the anterior portion of the spine for resection, for anterior fusion. And although technically challenging, it gives you the ability to correct large sagittal plane deformities, particularly congenital ones, with a posterior-only approach. Pedicle subtraction osteotomy is also valuable for fixed sagittal plane deformity. It's felt to be associated with higher risk. It's technically challenging, but probably equal to Smith-Peterson osteotomies, with one report suggesting the blood loss was greater. There are some posterior techniques now of which I have a particular interest, and we'll talk about more today, which are growth-sparing posterior approaches to severe deformity, where you're trying to allow the chest and the spine to grow while preserving sagittal balance. This is one example. Growing rods are another way to posteriorly try to control deformity, but certainly have problems with other aspects, such as sagittal plane failure above and below constructs. We'll talk about that more later. So in conclusion, I think posterior-only approaches are certainly versatile with a variety of deformities. The posterior pedicle screw constructs really allow the same correction, and I think will show the same number of selected fusion levels as the anterior approaches. At least in theory, it avoids violation of the chest wall and preserves pulmonary function. And finally, the osteotomies that are now used with better internal fixation allow correction for more severe deformity from a posterior approach. Thanks.
So now we're going to shift, and Dr. Ted Wagner, who works at the University and at Children's Hospital, and he's going to talk about anterior and posterior when you actually need both of them.
Thank you, Rick. I think Dr. Song and Dr. Smith have really spoken around this subject quite a bit, and I will only add some historical perspective to this. I think that tuberculosis was really the great teacher for approaches to the spine. Remember that when tuberculosis became a retroperitoneal problem, it would drain. It would either drain down in the groin or it would drain around the side, and there were very specific sites. And really the surgical approaches were just the reverse. You reversed tuberculosis, and that's how you got there. So Hodson and Yao were in Hong Kong at a time when tuberculosis affected about every 100th person. And so there was a great deal of anterior surgery done there. And when it came to deformity, they really initiated some of the early deformity, and out of Australia came Dwyer. And so most of the deformities in Hong Kong were actually done so that you would expect to get 50% of the correction anteriorly, putting in the Dwyer instrumentation, and then roll them over and do the posterior part and get another 50% correction. And so that era really existed from almost all of the late 60s and the 70s. The anterior releases became those of discectomies and then correction with either Harrington or segmental fixation, the Harrington rods coming first. And so the real goal here was to make the spine more mobile so that you could get a greater correction when you did instrument posteriorly. The interesting part was that the three-stage operation started. And those were the places where you would resect anteriorly. You would then expect to get a significant correction posteriorly, but now you left a big gap up front. And so now you had to go back to the front and put in something, either in the form of spacers or bone graft. And those the three-stage operations became a long day, or they became usually a staged type of procedure, depending on where you were. The anterior thoracoscopic releases were really, again, really developed out of general surgery. The thoracoscopic approaches became something that we became intrigued with, and I think that Dr. Song and Dr. Smith have touched on that, and I think that I talked to Dr. Peter Newton just 2 weeks ago, and he is down to doing about a half a dozen only a year, whereas he was doing significant numbers before. And the indications were really someone who had the absolute ideal case of a very flexible thoracic curve in a woman who absolutely wanted the procedure done that way. So he, after he explained it to them both ways, unless they really wanted it that way, he chose to do it differently. So you can see this trend moving away from that. So I think that what we're really talking about today is the utility posterior approach. And I put quotes around it because I just sort of made it up, but that's really what it is. And we're able to get there from almost any position. Utility is usually used for utility baseball players who can play all positions, and I guess the surgeons also can try to get to almost anything from the back. And so I think you can actually resect the vertebral body. I think you can resect discs. I think you can use this along with posterior segmental instrumentation to your advantage. And therefore you can really take on this severe kyphosis or the corpectomy and tumors, the unbalanced sagittal balance, and the pedicle subtraction and osteotomies. So I think I've said what the others have said today, and I think that if there is a trend, it really is there. I've often showed this case, and it's a little bit like Dr. Smith's, but on On this right side, we have a young girl who presents with a she's 18 years old, and she presents with 140 degrees of kyphosis. And really, an anterior approach is almost impossible. How would you get into that little area, working down in the apex of that, and try to do something? Really, the answer is that it's easier to get it from the back. And so the costotransversectomy approach to this actually becomes better. This is only to illustrate that if you take an AP X-ray, you get what looks like a CT scan, because you're looking right down the canal. It's with that much deformity. And when you get there, you can put your instruments in above and below, but then you really can resect all the way around the spinal cord. So this is the spinal cord, the surgeon's finger, and you can work around the entire spinal cord. And the cord seems to tolerate this quite well as long as you don't distract. Okay, so you must hold it in neutral position and you must compress it, but you cannot distract the spinal cord. And so the procedure has been quite workable. And in the end, this is done a while ago, and the way we used a 4-rod construct is a little out of date, but it actually shows that we corrected this kyphosis down to about 40 degrees. So we took 100 degrees out, all going from behind, and doing it through costotransversectomies on both sides. And this allows you to get that complete correction of her spine. And then I did have a 12-year follow-up on her, and she's healed and done well, and went, as she says, from non-marriageable to marriageable, and that was her greatest compliment to me. I think when you look at the unbalanced curves that we see every day in the thoracolumbar of the scoliosis and kyphosis combined cases, that there still are some cases that are very stiff in the adult. And when you try to do bending films on them, you really can't get any effective bending. And I think that, therefore, there is a place still to consider the anterior releases. And this is a patient with an 80-degree curve, very stiff, 40 degrees of kyphosis, and done recently. And I think that I don't have the confidence that I can do all of these curves posteriorly. And so in this case, we actually, this is her immediate post-op, and we've actually reversed her unbalance. She was unbalanced in this case to the left, and when we finished, she is unbalanced to the right. So we've corrected her 80-degree curve completely. But in this case, we did an anterior approach, and we did 1 week later, did the posterior approach. So the pedicle screws fixation is a very, very strong system. However, you can't really get there without doing osteotomies at almost all your levels, at least throughout the apex, in order to correct it. And I think that's, history goes in cycles, and I'm going to try to put that up. But this is her 1 month after her surgery. She really is very pleased. She's standing up straight now, and she's a little unbalanced to the opposite side. So in looking at this, I think we started with posterior only, as Dr. Smith said. We then went through a very strong anterior approach only system. We then came to anterior and posterior, and I think in the big training programs, we're moving more and more toward this utility posterior approach. And I think for all of us who have trained in different places, I think we see that trend coming or has arrived. But I don't think you have to throw out what's been done before, because I can imagine that this circle is going to go right around again and again, and that's what usually happens. It takes 10 years to prove you're wrong in most orthopedic procedures. So look for the 10-year review on anything that comes out new, and usually it will reverse your thinking again, and you'll start over again. But my feeling is that this is where we are in 2006. In summary, I think you can do most of this surgery, certainly if you use the combined approach, and I think that for special tumor resection, some old fracture pathology, some severe scoliosis. One of the problems we didn't talk about is the cases where we have to go anteriorly, and that is the removal of broken anterior instrumentation. No one ever likes to put in instrumentation anteriorly and have it break, because it's a permanent X-ray that all of the generations of spine surgeons in the future will see, because they will all X-ray them and all see the broken rod that someone left in. So there are some cases where I think the combination is necessary in order to remove some of that instrumentation. And finally, I think there are certain infections where the disease is certainly anterior, such as tuberculosis, and I think that clearly they should be done anteriorly, and they almost all need to have a posterior fixation. So I thank you and leave the topic open. Thank you.
The topic I was asked to give is slightly different from what you have written in your program. It's basically the iliac fixation for caudal instrumentation failures, in particular after long thoracolumbar fusions, but in general. On that note, I'm going to discuss a little bit the clinical and biomechanical results of the use of iliac screws. And I'll start with that. This is actually a paper that Marcel just referred to. It's a paper that demonstrates or tries to indicate when you should really be using iliac screws in primary situations with thoracolumbar fusions, or thoracolumbo-sacral fusions more accurately. And what they found at UCSF is, again, especially if you have any issues with restoring sagittal balance, you should probably go to the ilium from the get-go, because you have a high likelihood of fixation failure if you stop at S1. If the patient has poor bone stock, then even more so. There's really only one paper out so far that I'm aware of, and it just came out this year in Spine, that has any kind of reasonable long-term results with regard to iliac screw fixation at the caudal end of long constructs. And the results of this study out of Washington University actually did confirm that the use of iliac screws is actually very effective in preventing at least what you'd call catastrophic failure or instrumentation failure with significant kyphosis at the caudal level. They did still note a significant pseudarthrosis rate down in the lower lumbosacral area, but what they noted is it presented primarily as pseudarthrosis with reasonably good preservation of alignment and screw breakage, rather than, again, a significant fixation failure that would lead to more complex reconstructive need. With regard to biomechanical studies, there's a couple that I find are useful. This study here out of Baltimore, and Ted looks like he was involved with this study here. It was primarily out of a biomechanics lab in Baltimore, shows that as compared to supplementary sacral screws, i.e. S2 screws, or intersacral rods, iliac screws are much more effective in not only relieving the strain on the S1 screws in general, but particularly in preventing failure under catastrophic loading conditions. Again, in this situation, they showed that yes, S2 screws did to some extent protect the S1 screws, but not really to a great degree, and again, not under failure loading conditions. And they found that there was really not much benefit to intersacral rod placement, since they really didn't provide much more stability than S2 screws do, and obviously are a little bit more futzy or complicated to use. Another biomechanical study actually looked at is the use of iliac screws better than simply adding inner body support to a construct which ends at S1. And again, the findings were that iliac screws are more effective at restricting motion at the lumbosacral junction, and they're more protected of the S1 screws. And I think the last line you see on the slide here says it all. What they found is if they did use iliac screws, the construct failures with failure loading conditions occurred rostral to the construct, whereas when iliac screws were not used, they actually occurred through fracture of the sacrum below. So iliac screws, obviously very effective in protecting caudal fixation, and the bigger question, I think, rather than should they be used to salvage caudal fixation failures, the answer of which being, of course, yes, the bigger question is when you should really use them in the primary cases, and I think Marcel addressed that to some extent. Just briefly, other biomechanical studies have shown that iliac screws are also very effective in other highly unstable situations, such as sacral fractures. This is a paper, and as you can see, this is zone 2 sacral fracture, paper done here by one of our former fellows, Thomas Schildhauer, who's now in Germany. and a bunch of his colleagues here in our department, and our biomechanics department as well, demonstrated that the use of iliac screws with sacral fractures far superior to other more conventional screw fixation systems, such as iliosacral screw placement. As you can see on the right here, the displacement for a given load being much higher with the iliosacral screws and with the use of the iliac screws themselves. With regard to technique, really not a very complicated technique. I'm sure almost everyone in this room has to some extent placed iliac screws before. I'll just describe the way I prefer doing it, and you guys can decide whether this is something that you find useful or whether you prefer the technique you already use. Depending on whether you use modular systems, for instance, top loading versus side loading systems, I think the technique can vary significantly. I prefer to use a fixed angle system primarily because I think it eliminates in this high loading area, I think it eliminates yet another potential cause for failure, which is the failure through the modular hinge, if you will. So I prefer to use just a fixed angle system, and because I prefer to use a side loading system, it makes it very convenient to actually, after you've done the rest of your instrumentation, to simply contour the rods appropriately with sort of a double S type contour, as you can see here. Sort of contour back along the sacral kyphosis, and have these rods actually pre-positioned, which allows you to fine-tune your starting point according to where the rod is already placed. Otherwise, to place all the screws independently in a non-polyaxial system and then try to make the quite difficult contour between the lumbosacral pedicle screws and the iliac screws can be significantly more challenging. Again, Thomas Schildhauer, again, former fellow while here at Harborview, had a very productive couple of years here at Harborview, in conjunction with our radiology department, did a CT study which looked at possible channels possible bony channels that would be amenable to iliac screw fixation. And what they found was that there are essentially 3 channels that can be used. The 2 primary ones, I would say, are the PIIS or PSIS to the anterior inferior iliac spine channels along the sciatic buttress, basically, and also this iliac tubercle up here down to the anterior inferior iliac spine channel, although I tend not to use this one quite as often, primarily because as you go up that proximally, you also tend in the coronal plane to go out more laterally, and that makes it a little bit more of a fiddle to use. But what he found was that in most males, the size of this bony channel could accommodate 8 millimeter screw diameter by 130 to 140 millimeter screw lengths, whereas in females, 1 millimeter less in diameter by 120 to 130 millimeter screw lengths. As far as technique goes, everyone I think is a little bit different. What I prefer to do is to use a true lateral of the pelvis as my primary view for placing these screws. And I'll go into this in a little bit more detail, but the key here is to have a perfect overlap of the sciatic notches so that you're sure you're getting a true lateral view and that you're not getting fooled. This is, you can tell that this art here was not done professionally, it was done by me, so I'll try to explain it a little bit just to make sure it makes sense. I'm trying to demonstrate here the use of various oblique views in the placement of these screws. This, of course, is the patient lying seen from the side, and this would be the patient's head, eyes, nose, and you're looking at them down the axis of their body from the head. And so this is demonstrating an obturator outlet view whereby the gantry of the C-arm is tilted as an outlet view in this plane and as an obturator view in this plane, which really gives this teardrop appearance here, really shows a projection of this sciatic buttress that I was just talking about and the channel in which you intend to place the screws. And this is a good radiographic view. Really, I find it more practical for screw verification. I know some of my colleagues use it actually to determine the starting point, but I find it a little bit cumbersome for that. By keeping the C-arm, again, in this obturator outlet position, but instead tilting from an outlet to from an outlet to an inlet, then again you get this this shot down the you get an inlet view, but you get a shot down right down the iliac wing, which shows you very nicely the inner and outer tables, and again can confirm intraosseous screw placement. And the last one I like to use is just simply the iliac oblique view, which is a good view, as I'll demonstrate in a second, to show screw length and appropriate positioning above the sciatic notch. So this is ideally where you would like your screws to go, right between the inner and outer tables, all the way up to the AIIS, and even if there's a slight bicortical penetration, I think that that's even advantageous rather than detrimental. So here's the lateral view. Again, the important thing in the lateral view is to make sure you stay above the sciatic notch. Obviously, you can also ensure that you're above the acetabulum, and you get some sense of screw length as well if you can visualize the AIIS nicely, although it's not always easy to see. As far as the iliac oblique view, again, shows very nicely the sciatic notch. Make sure you're above the sciatic notch. And this actually, I think, is the best view to demonstrate the appropriate screw length, as it shows the iliac wing in a really nice projection. And you can also get a sense, too, to ensure that you're above the acetabulum. As far as the obturator outlet view, again, this is the view that's obtained actually along the axis of the screw trajectory, and you get this nice teardrop shape. And the goal, of course, is to keep to visualize the entire screw trajectory within the teardrop itself to ensure that you haven't penetrated laterally or medially. And now the same obturator oblique, but the inlet version showing that your screw is between the inner and outer tables. And these other views can also be used to supplement that. I'd say a final word I have about the technical aspect of placing iliac screws is these screws can be very prominent. If they're placed right on top of the iliac crest and they're left prominent, they can be quite problematic. I've actually had patients who have developed decubitus ulcers from those screws just from lying in bed post-operatively. And so it's, I think, imperative to make sure that your starting point is a little bit more medial, and also that you recess the screws as demonstrated here and make them at the very least level with the rest of the posterior crest. In fact, maybe even slightly more so than this CT scan demonstrates. And just an illustrative case. This is a patient who had an L4 to S1 instrumented arthrodesis. We just presented this case at NASS, actually. And a patient had an acute increase in her back pain in the relatively short post-operative period. You can see here in these sort of reconstructed views, this was the immediate post-op visualization here, or study here, and you can see that the patient here has androlisthesis of the top of the sacrum with respect to the bottom of the sacrum. This shows you the fracture. It's obviously a transverse fracture, but in order to have displacement at that level, you need to also have sort of either a U or H-shaped component as well. Sometimes these aren't quite as obvious. I think it's important to make sure that you rule out this problem in patients who present with really acute low back pain that is difficult to discern sometimes, that's really out of proportion to what you would expect in the postoperative period, or maybe a sudden increase in low back pain. They may have a sacral fracture that's not that displaced and not entirely obvious, and bone scan may be useful in making the diagnosis in those patients too. Patient with the degree of displacement I just showed really has a much more complex sacral fracture than simply a transverse fracture. They probably have a U or an H variant, and it's a highly unstable situation where the spine will basically slide forward and kind of caudally into the pelvis unless secured, and iliac screws are a good means of doing so, securing these, and this is exactly what was done in this case. Here's the post-operative CT. You can see that the patient reduced nicely on the table as well, and she's remained in acceptable alignment post-operatively. So anyways, to conclude, iliac screws are indeed the best caudal fixation anchor we currently have available. It doesn't mean they should be used in all patients that are undergoing primary long thoracolumbosacral fixation constructs. However, they certainly are an excellent option for stabilizing caudal fixation failures, and I would say that they are the treatment of choice for such failures. The anatomy provides the opportunity to place long pedicle screw or long iliac screws, and an understanding of that anatomy and understanding of the various oblique views you can use to either place or confirm the appropriate positioning of these screws is helpful in keeping the screw placement safe and optimal. Thank you very much.
We got a little time for questions. First of all, maybe I'd ask Kit and John. One of the big arguments that's come up in the past has been whether you can preserve motion segments by doing anterior only versus posterior, and certainly with the more powerful constructs. Do you still see that as an issue, and how do you discuss that with your patients?
I think that it's interesting to watch the sort of evolution, especially coming out of St. Louis, because I think Larry Lenke and Keith Bridwell have done really some tremendous work over the years talking about different approaches, and for a long time it was all anterior. You can save levels, especially at the caudal end. But I think their recent work has shown us that with good fixation and with good pedicle screw fixation from a posterior approach, that you don't necessarily save levels. So I think that's an evolving target. And I would say anymore, I'm not so sure that that's a compelling reason to do an anterior-only approach.
I'd agree with that completely, and I think, you know, the evidence in the literature is certainly supporting that pedicle screw constructs posteriorly can suitably treat, for example, the thoracolumbar curve that was a classic anterior instrumentation approach curve with the goal of saving a distal fusion segment. And I think the literature supports now that you can do it all posteriorly. I certainly do now.
Can I ask Dr. Redding, what is it about a thoracotomy that reduces the lung function? And is it important, do you think, in idiopathic scoliosis? I mean, is it the fact you remove a rib, or maybe you don't remove a rib, whether you do it extrapleural, intrapleural?
I don't think it's a simple answer, and I don't know the answer to your question, so let's start there. I think a lot of it has to do with distensibility, and I go back to pain and diaphragmatic function and distensibility of the chest wall. I don't think it's a pulmonary process per se. It's a constraining process.
Question back.
If we have anterior hardware that needs to come out for whatever reason, are there any specific tests that we should obtain to make sure that the blood vessels and other vital structures are in safe distance so we have adequate resources to combat that? Are there any suggestions in terms of proximity of hardware or type of hardware to the great vessels, for instance?
I don't have a big enough series to give any definitive answer, but I think that these are the ones where, if you're a surgeon, as I've been doing all my own anterior approaches, I think this is the one place where the vascular surgeons are really should be part of your day, because some of them are easy. It's really quite easy to take them out, and others aren't. I think that the angiogram or the arteriogram has been what we've used. I don't know whether MRI can really help, because usually these are stainless steel, and therefore the MRI is not very helpful. So I think you have to go to a interventional test.
Just at least with adults going from the other direction, who does generally use approach surgeons, I think this is the time that you need to be there as well, because certainly with the great veins, I find it easier to actually take a sliver of bone, a wall of bone up, and elevate the whole vessel up, rather than meticulously dissect off this fragile and scarred vein. So I think you actually kind of need both of you there. Sometimes a compromise approach seems to be the safest.
Kit, you want to?
No, I would echo what Ted said. We've had to go in a couple of times on hardware, and I think that the angiogram is a critical piece, and I've routinely used the general surgeons in our approach to that. The MRI angiogram we've tried once. It's not useful. You can't see because there's too much artifact and distortion from the metal, so it's really not practical.
In our experience when I was in Denver with Mike Jansen, we did a study looking at CT angiography for approaches to the anterior spine, more specifically in regards to the disc replacement, but looking in general to revision cases and other things. The advantages of it is you get a good idea spatially where the vessels are, and you can divine scar tissue, other anomalies in the front, and also in regards to your bone defects, where your hardware is, and the spatial problems in regards to that. In regards to the ureters, and all the other structures, not just the vessels that are there. And it's a good technique. It's one study that gives you a vast amount of information before you go in there, and allows you to realize what you're dealing with before you get in there, and to be able to prepare before you go in there. And again, the vascular surgeon is probably the best thing to have alongside with you.
Let me just ask a follow-up question to the initial one then, and maybe Jason, you want to take a first stab at it, and anybody in the audience follow up on it then. How should we counsel a patient where a metal object of surgical origination lies less than 1 centimeter of one of the pulsatile great vessels, or less than 1 centimeter of one of the non-pulsatile great vessels? Is that something that should come out because of the risk of a late erosion? How would you counsel a patient, Jason?
I'm not sure about where the literature is going with that. I mean, I think it's there. There's case reports of it being eroded through, but I bet you there's probably more anterior hardware or even our posterior hardware that's anterior that has come close to the vessels in the front there and the pulsatile vessels, especially at the craniocervical junction and other things. And the question is that really a high risk enough problem? I think it has to come into how much that's deforming the vessel and probably following it over time. I don't know if going in immediately just because it's there, but counseling them saying, hey, this is what's going on, and we probably should take a look at it, probably have a consultation with a vascular surgeon to evaluate it and probably take a look at it, visually, either with an angiogram or other things, to make sure that there's not a significant erosion, then also follow that patient up over time. I think that if there's significant indentation of the vessels, that it's probably in a pulsatile vessel, you have probably a higher risk of potential complication in the future. And once your fusion or whatever you're trying to attempt to achieve is finished, then probably going in there and removing that is probably a wise thing to do.
I think, Jens, I think this has come up a lot in the thoracoscopic stuff, and Peter Newton did a nice animal study looking in, I think it was pigs, and pedicle screw penetration that was intentionally created. And there were two things. In the growing child, what was interesting, or in the growing animal, was interesting that the screws eventually grew away from the aorta. So if you have a sort of a minimal impingement in a growing child, it may be worthwhile to follow that over time and see. What I think he showed very nicely is if you have indentation of the vessel, that you're going to get thinning of the intima and all the layers of the vessel, and that's very worrisome. So his recommendation was if you have indentation of more than 1 millimeter, that you consider taking the screw out or the affected hardware out. If it's 1 centimeter away, I don't know that there'd be compelling evidence to say that that should be removed.